mimics as well. Okay, so it's my pleasure to introduce our last speaker, Dr. Jordi Mouchard, who's a pediatric neuroradiologist who works at the Hospital San Juan de Dios in Barcelona. Welcome, Jordi.
Thank you very much for the introduction. I'd first like to thank the organizing committee and both societies for the invitation. It's a pleasure being here and in person, so thank you for that. And I'm going to speak about how we can add, how we can help in the surgical process itself. I have no conflict of interest, and I'd like to start with a case. This is a 5-year-old girl who presented at the emergency room with headache, nausea and vomiting, and papilledema. So they ordered a CT scan, and as you can see, we have a, sorry. Oh yeah, thank you. So as you can see, we have a midline posterior fossa tumor. It looks quite high density to me and some calcifications. It might arise or be in the fourth ventricle, and there's hydrocephalus as well. So we went to the MRI, and we did, this is important in pediatrics, in the same procedure, both in brain and spinal MRI. And we have low ADC, we have an expanding lesion. We can say truly that it's inside the fourth ventricle. We cannot differentiate how it arises here in the floor of the fourth ventricle and the cerebellum. There is heterogeneous T2 and also some bleeding inside the lesion and some contrast enhancement. And in the spinal MRI, we can see better here that we have some leptomeningeal nodules, so there are metastases. I would suppose it could be a medulloblastoma group 3, and the patient was scheduled for surgery. And they ordered an intraoperative MRI because at one moment there was some bleeding. This is the susceptibility imaging before surgery, and in this first scanner in the OR, you can see there is more bleeding here, and they were a little bit lost. They knew there was some tumor arrest there, but they didn't know for sure, and they wanted to update the neuronavigation system as well. So this will be the intraoperative MRI that we did, and as you can clearly see, there is a huge amount of tumor here close to the left cerebral peduncle, which looks very, very similar to the previous MRI. You see there is low ADC here. Even the edema is a little bit less here, but the rest of the tumor looks identically. So definitely there is tumor here. At the same time, we can see that they have not come into the dorsal part of the brainstem, which is always a very, very dangerous area to come into. And they went to the OR again. And this will be the first intraoperative MRI I show you, and the second one. And as you can see, they could safely remove all the rest of the tumor. There is just one tiny nodule here that they re-inspected, and they said it's just some material that we had to put inside in order to stop the bleeding. And at the same time, as I told you, the dorsal part of the brainstem is okay. So I think this is a pretty good job, because what's the rationale of intraoperative MRI? It's aid to safe and effective neurosurgery. In one hand, we have the tumor, so we want to improve the extent of resection, but at the same time, we have to keep and improve patient safety. This is very important because what we want for our patients is high survival, but also low morbidity. And there are some things that we can do, not just intraoperative MRI. Another imaging technique that they manage themselves will be intraoperative ultrasound. There are other things that we can do. Presurgical studies and intraoperative neurophysiological and monitoring. So you know we have a lot of different techniques for locating motor areas, language areas, DTI for many different tracks, but all this information has to not only go to the images, not only go to the report, but also we have to import them in the neuronavigation system. This is a place where they will be more useful. And regarding intraoperative neurophysiological monitoring, this is something that our colleagues from the neurophysiological department do, but I wanted to comment on that because it really makes the neurosurgeon feel safer, especially in posterior fossa tumors, because we want to protect the dorsal part of the brainstem before any damage is done. Here with MRI, we will be late. Some damage will be done there. So it is their job to help the neurosurgeons. But we have to take that into account because these needles that they put in different places to monitorize cranial nerves, of course, are metal made, and they must be MRI compatible in order to use it in the whole intraoperative MRI procedure. Otherwise, you will have to take them out before the patient goes into the MRI, and depending on the needles, especially when you want to monitorize lower cranial nerves, you will not be able to put them inside again. So this is very important to check it and to do it before any procedure. And what about the extent of resection? Either it is the goal, it's gross total resection or partial resection, we can be of good help. And the maximum importance comes where surgery has the highest impact in survival. So it will depend on the tumor itself and in the location of the tumor. We have our presurgical imaging diagnosis, which is very important, and of course, intraoperative pathology. And there are some kits, some rapid tests that sometimes even can currently, say if there is some molecular abnormalities in tumor during the scan, during the surgery itself. But this is not so common. And of course, it would depend on other therapeutic options that that tumor may have. This is mandatory in ependymoma, especially in young children, which in group A is most common, because surgery has by far the highest impact in patient survival. So we have to do our best here to help them, and if it is safe, try to resect as much as possible. Regarding medulloblastoma, this is not exactly true in the context of the molecular area that we have just started to know, because depending on the subgroup, it will need more or less resection in order to be effective. But as we still don't know this information during the surgical procedure, they try to resect as much as possible. So if this was the final MRI of a patient with a medulloblastoma, this patient would need, apart from the standard craniospinal irradiation, will need a boost in these areas. So leaving tumor here really can get to higher morbidity in the mid and long term of the patient. It is the opposite with pilocytic astrocytoma. As we can see here, there are huge rest of the tumor, but it is fine because these patients have good long-term survival, and what we want is them to have a long-term survival with the highest quality of life. So depending on the areas, here the superior cerebral peduncles that, as I will show you later, we have to avoid damage to these areas. If it is a final intraoperative MRI, it is not bad, it is okay. It's better for the patient to stay in the safe side in this context. So, what about improving preventive safety? We can protect or help to protect eloquent areas and avoid posterior fossa syndrome. If we can avoid reoperation by detecting these areas during surgery, and it is advisable to try to use this MRI as the baseline follow-up if possible, in order to avoid the new anesthesia in the next days for the patients. So one area to protect, of course, will be the insula, and especially vascular regions related to cerebral artery lesions. In this case, this patient had a pilomyxoid astrocytoma. This will be the preoperative scan. And as you can see, there is a tiny nodule here that we knew, and the surgery knew it was tumor, but it was left there in order to avoid surgical damage, surgical spasm, and to avoid an infarct of the left cerebral artery. So it is okay. And regarding the posterior fossa syndrome, this is a very serious issue. Reported incidence is quite high, and it is a devastating condition with long-term effects. Some patients even don't go back to a standard speech and standard behavior, because it affects neurophysiological, neurological, and language and speech areas. It consists of irritability, ataxia, hypotonia, and dysarthria. And in this setting, I think it's the opposite that we discussed regarding intraoperative neurophysiology, because this pathway, this pathway that goes here along the superior cerebral peduncles, which has been related as a risk factor and something to avoid bilateral damage to this part, the knowledge of this has also come from the extensive use of intraoperative MRI. So we can not only use it as a tool, but we have to analyze our images and gain knowledge in this area too. So we have to avoid this. And intraoperative neurophysiological cannot monitor this area. So it is the knowledge of the surgeons, be careful with this area, and as advising them, you are too close to that, they can avoid this syndrome to happen sometimes. This was a patient, a 4-year-old boy with a medullostoma group 4. You see that this is a very, very big lesion, and the patient was scheduled and surgery tried to remove it all. So in one hand, it would like it is a good thing, but apart from the infarctions you see here, there is bilateral lesion to the cerebellar peduncle, most on the left side, but also on the right side. And unfortunately, he did not recover from cerebral posterior fossa mutism. What about the use of our scanner, of our last intraoperative MRI scanner as a baseline follow-up? You can do it, but it will depend on what your institution thinks it's okay, because it has only been validated in few studies. It has been validated if you do it in a 3 Tesla scan with a standard protocol for brain tumor, and if, who reports this is someone who is experienced in this kind of tumors in consensus with the operating neurosurgeon. This is due to the quality of image, because as we show you, depending on your setting, the quality of image that we will have with this kind of analysis of studies, of MRI scans are not the same. And how we can achieve our goals. We know we can detect residual tumor, we can identify critical brain regions, and we can update the neuronavigation when the accuracy has been lost. But at the same time, we can identify immediate postoperative complications, and what I think is very important is to give immediate feedback. Immediate feedback to the neurosurgeon is very important. Neurosurgeons who are very, very experienced, they will say, I don't need that. But when you talk with the people that work with them, that are still developing their career, they find it very important because they know why I left this part of the tumor there or not inside the OR. So you mean the learning curve looks that it's going to be shorter. And how can we do it? We will be an example of a normal workflow. First, be prepared for the case. This is very important. Then the patient goes to surgery. They decide if they think they take it all out or they go for an intraoperative MRI, and we check if there's residual tumor. Of course, going back to the surgeon and say, okay, you left something, I think it is better that you go inside. It's not an easy thing to do, but I think it's a teamwork, and with time, you establish a good relationship that they trust you. So once we know if there is residual tumor or not, we should ask us if further resection is safe. And if it is safe, we go back to the surgery. And I just wanted to tell you that it is not the MRI scan. This is just part of the equipment you need. You know, there are 2 major options. Either the patient goes to the MRI scan or the machine moves into the patient. But it's not just the magnet. The system to pin the patient in the selected surgical procedure is key because we need high-quality coils. Dedicated intraoperative height coils will always do much better than surface coils. So if you can, go for this. And this information, of course, has to be integrated into the neuronavigation system. There are specific issues in pediatrics. Surgical positions, especially in the posterior fossa, are a little bit different, and head size and bone thickness can present us with some problems. Regarding sequences, what you have to do is, have a protocol that is comparable to the diagnostic MRI. But especially, I think it is advisable to use non-echoplanar imaging diffusion in order to reduce susceptibility artifacts. You can also help and overcome this problem by working with the neurosurgeon and filling the cavity with a serum because it gets the air out, so the image quality is better. And at the same time, some authors, and I think it is a good idea too, that in the posterior fossa, you could use 3 different thin acquisitions in T2 to look for, better look for possible residual tumor. So we've discussed some imaging issues. I haven't discussed MRI safety protocols, but as you can imagine, having an MRI in the OR can be something dangerous. So pay a lot of attention to the safety protocols. Also, quality of imaging has to be very high. And we must be there. Direct supervision, I think it is mandatory in these cases. And there are time constraints, so be prepared for the case. We should know the appearance of the original tumor and some imaging challenges, as I said, susceptibility artifact, but I have to say that you can even have surgical induced contrast enhancement in the intraoperative MRI. It's not a common thing, but you can have it. And be aware of brain tissue deformation. And at the same time, be humble in to say that we cannot always tell. So establishing a good relationship with your neurosurgeons and asking them to inspect those areas that you are thinking are doubtful is a good way to go and to improve in the midterm treatment for these patients. And where are we now? Well, of course, there are much more papers that cover, well, there are few less papers that cover intraoperative MRI in pediatrics, but there are a few of them. And we're moving to high-field magnets. Safety is proven. I didn't cover this topic, but infection anesthesia complications are the same as without the procedure, in the sense that, the MRI, makes surgery longer. Of course, we can have greater safe and extent of retention, but long-term outcomes are missing. This is because we don't have randomized trials, so we compare this series with previous series without this aid, and data rate as level 1 in pediatric neurosurgery are scarce. Other uses of this tool, of course, biopsy guidance and target assessment, cyst fenestration, and catheter placement. And of course, it opens the path for developing and testing new guided MRI treatments. From these treatments that I selected, in which I reviewed, I think that are the most common that we see in different congresses, lectures, I am just going to cover MRI-guided laser interstitial therapy. But I have to tell you that, this kind of, This kind of devices are also developing in pediatrics, in preclinical trials, to try to give specific drugs to certain targets, especially in the IPG. I know you have more experience here in the States because, as you can see, this device was approved by the European medical agencies in 2018. And this technology comes from here, from the United States. And what you want to do with this kind of treatment is to reach a thermal ablation of the lesion. So we plan carefully with the neurosurgeons how to introduce the needle in order not to damage any critical area, to avoid vessel damage as well. And once we are there with a catheter, you introduce a fiber laser whose tip you can hit. And depending on the design of the fiber, you can get bigger lesions or different shades as well. And you do this while the patient is inside in the MRI. I'm not telling that the only way to do this is with an MRI close to the operation theater, but of course it is much more easier to do that. And while you hit the catheter, what we do is we acquire MRI thermometry sequences that provide us an accurate map of what we are doing. This is a real-time image from one of treatment. This is in hypothalamic hamartoma. But you can see here in number 2 that we can have temperatures as high as 80 Celsius degrees, which I think would be 180 Fahrenheit, which is quite scaring at the beginning. But at the same time, we can have other points in which we can protect the areas that we select. So we do it like this. We left some cooling time for the tissue, then we acquire some images in order to see how it is doing. Diffusion and T2 are the ones that we use most. And as you can see here, it is a little bit different. I mean, the T2 is getting higher. And in this case, in hamartomas, we don't want to ablate the whole lesion. You can do it if possible, but the main goal of the treatment would be disconnection. And what this has to do with the topic of today, because we are discussing about brain tumors. Well, in pediatric, in some specific cases, some people are starting to use this kind of techniques. Why? The clinical setting will be you have a cortical lesion that we think is a low-grade tumor, and the patient has seizures that are refractory to medical treatment. And the lesion is a small one, but it is a very high-risk area. So what can we do with these patients? And the treatment goal here is control seizures, because the oncologists say it isn't necessary to go there because we can wait, let's see how we can do. And another important thing is that these systems allow needle biopsy and treatment ablation at the same time. This is a case I'd like to share with you. This is a 12-year-old girl with an F1, who in 2014 already had this lesion. You see this lesion is cortical based, but also has subcortical in the premotor cortex, so it's a high-risk area. And we did some follow-up. We did nothing because the patient was fine. But in 2021, she started to develop seizures that were very, affected her quality of life very much. And at the same time, we started some treatment, but they became refractory to the antiepileptic drugs. So we decided to try this treatment together with a neurosurgeon because we thought that the area was of high risk. This is flare T2 immediately after the treatment. There is some bleeding here. You see that the area has increased in size, probably due to edema during the treatment. The biopsy was diagnosis. We had an intraoperative review of what we could take out in order to see, okay, it looks like a growing glioma, go ahead. Final diagnosis was a DNET, and in the 1-year follow-up, we cannot see any part of the area that looks like rest of the tumor or a relapse. And the patient is seizure-free under medication without any deficit. So I think that for specific cases, it could be a good option. And with this, to summarize, I'd like to just say that it is a safe and useful technique. It allows the development of new therapeutic options, and it's a teamwork of many people, from neurosurgeons, the oncologists, the lab, the imaging department as well. And I'd like to thank all the colleagues of my hospital for this, and all of you for your attention. Thank you very much.